Thank you, Mahesh. Thanks, Kumar. You came across a very passionate buckler. But passions also die down over a period of time. And let me tell you, my passion for buckle has slowly come down in the last decade. And I'll tell you why. Um, 10 years ago, whenever I saw a patient with a detachment, a fresh detachment, my thought was, how can I buckle this brake? Wherever the brake is, whether it is anterior, posterior, the question I used to ask myself is, can I buckle this brake? Can I put a buckle to close this brake? If the answer was yes, I went ahead and did a buckle. So that means our primary approach at that time was to do buckle in almost all cases of fresh retinal detachment. I'm not talking about detachment with PVR, macular hole, giant retinal tear, etc. We're not talking about that particular subgroup. There, vitrectomy is necessary, absolutely. So we had to justify why I did vitrectomy in this patient when I could have got away with a buckle. But today, 10 years down the line, does it still hold true? No. Today I have to justify a buckle. If I have to do a buckle, I have to say why I wanted to do buckle in this patient instead of doing vitrectomy. And that's how the whole thing has changed. Why this trend has taken place. Let's just look at the number of articles published in the literature. Since 1956, there were 2,745 articles on scleral buckling, but look at the number of articles on vitrectomy after it got started in 1970, 12,341. And from that time to now, only about 1,000 articles on scleral buckle has been published. And if you look at the last 5 years, 395 on scleral buckle, 3,000 on vitrectomy, and 234 on scleral buckling and vitrectomy. So obviously something is happening here. People are favoring vitrectomy. Look at the Medicare claims. Vitrectomy doubled from 15,000 to 32,000 from 2000 to 2011. The same figures in that decade for scleral buckling declined to less than half, 6,000 to 2,000. If you look at this PAT survey, 2018 PAT survey, they compared 2006 and 2018. The question was, what is your usual surgical approach for a phakic inferior macula on RD with a tear at 6 o'clock? All of us would close our eyes and say scleral buckle. But look at the numbers. In 2006, 70% of them said yes, they would do scleral buckle, but the number came down to less than 60%, about 12 years down the line. So there is a decline in the art of buckling. Let's look at our own data. For this particular talk, I pulled out the data from our records. In 2008, we did 138 scleral detachments, out of which 77 were scleral buckle, MIVS was 0.9, and SB width was 47. Why is this SB width high? Because way back in 10 years ago, whenever we did vitrectomy for an RD, it was almost always combined with a buckle. It was almost a SB width. But today it's not so. Look at the figures for 2018. 129 retinal detachments. We did MIVS for majority of them, and scleral buckle has come down to 34. So let's look at UK database analysis. 1995, scleral buckle done for 83% of recommended retinal detachments. In 2014, it has come down to 12%. So why is this decline, and whether it really works better, scleral buckle better or vitrectomy better? Do we have an answer? We do have a large study, the EVRS study, which came out in 2013. They studied about 4,000 and odd eyes and compared 3 surgical techniques: scleral buckling, vitrectomy, and SB width. What did they find? They found that with this large data, phakic eyes, scleral buckling does better than vitrectomy or SB width. In pseudophakic eyes, vitrectomy is better than scleral buckling. But curiously, addition of a scleral buckle to vitrectomy did not really make so much of a difference. And today, let me tell you, in my own practice, I've hardly added buckle to vitrectomy. Even in complicated vitrectomies, complicated PVRs, we do vitrectomy first. Only if we have a recurrence, then we go and do a buckle if required in the second surgery. So why has this change taken place? Why have we favored vitrectomy more and more? There are reasons for this. One is refinements in the vitrectomy system, refinements in the viewing system, and declining skill with buckling. When a doctor is confronted with scleral buckle, as Dr. Kumar went went about his lecture, too many decisions to make. Have I got all the breaks? Have I got all the breaks localized properly? Have I got all the breaks covered with cryotherapy? Have I produced indentation on all the breaks? Because even if one break posterior to the buckle gets missed, you had it. You have a failure. Which buckle should I use? Should I use a 287? Should I use a 277? Should I use a 42? Should I use a segmental buckle, or a radial buckle? Should I encircle this eye? The most important question, should I drain this, and where to drain? So these are all so many questions that are going through our head, and we say, forget it, let's go and do a vitrectomy. That's all. You would have put 3 ports and do a vitrectomy and be done with it. So no wonder that today's retinal surgeons are going more and more towards vitrectomy, and the machines also have improved so much. So I still remember the days about 20 years ago when we used to have a Paswami vitrectomy machine. Then we went off to STTO, then we went on to Accurus. We had Stars, Millennium. So with each machine, the new machine, the vitrectomy did better and better. The cutting rates became better. We have 5,000 cuts. We had 7,500 cuts, and today we have 10,000 cuts, and people are talking about 20,000 cuts CPM. So that means the efficiency of the cutters are improving, and MIVS, let me tell you, it's been a great advancement from 20 gauge to a MIVS, because we could really do the same thing with smaller and smaller gauges. We could go closer to the retina. We have more control with the duty cycle systems in the modern machines. So therefore, now we can do vitrectomy much more confidently, much more efficiently, and producing much less iatrogenic damage than what we did 10 years ago. And additions like chandelier system expand our capabilities to manage complex situations, and the magic portion of PFCL fluid also adds to our capabilities. The viewing systems have undergone a sea of change. We all started off with the Landers system and the handheld irrigating contact lens system with the prisms and all that. And now with the Biome and its clones like Resight, etc., we can see the periphery of the retina so well. We can see all the breaks. We can do a good skirt excision, and even after fluid air exchange, we have such excellent view, and we can do laser so well. And most importantly, whenever you're doing a vitrectomy, there's no question of doing a drawing. You don't need to do drawing. So the fact of the matter is simple. The vitrectomy is the most rational treatment for retinal detachment because it relieves the vitreoretinal traction permanently. It cuts off the vitreous attachment to the horseshoe tear, and then it relieves the traction permanently. When you look at the laser versus cryo, laser obviously achieves a better addition of retina and the choroid than the cryo itself. It does so not by destroying large areas of retina like what cryo does. And we can treat large areas of retina with laser as opposed to cryo. If you had a large lattice covering one quadrant, imagine doing cryotherapy to the entire extent of that. Naturally, you're going to end up doing a lot of cryo, and this is not so good. And you'll have large areas of atrophy, which actually cause a lot of pigment dispersion. And of course, with vitrectomy, you have minimal ocular distortion, minimal refractive change. Of course, the single most important downside of vitrectomy in retinal detachment is causation of cataracts in a phakic eye. And that's, to my mind, is the single most important downside. Scleral buckling, you have to handle the tissues, it distorts the eyeball. Cryo causes more destruction, it induces refractive change. Healing time is more. And as I told you earlier, it does not relieve the traction permanently. And of course, the problem is it also needs more skill than vitrectomy. Now, which one of these patients have undergone scleral buckle? This is taken on day 1 post-op just last week. You can identify that this was the patient who has undergone scleral buckling, and this is a patient who has undergone vitrectomy. The only thing that tells me is I do cut the eyelashes sometimes, that this is the eye which has undergone vitrectomy. The eye is almost back to normal on day 1 post-surgery, following a vitrectomy. So, but does it mean to say that scleral buckling is useless? No, it does have a place. I think Kumar elegantly listed many situations where we would prefer to do scleral buckle over vitrectomy in our clinical practice. What are the advantages? Shorter time, it's an extraocular procedure. There are no lens changes, patient's accommodation is preserved, patient has no travel restrictions, if you don't use any gas or air, and in general, a buckle is a much more forgiving than vitrectomy. What I mean by that is that if you have a failure after scleral buckle, this is much easier to manage because you go and do a vitrectomy, remove all the membranes and whatever is causing attraction. As opposed to this, you have done a vitrectomy already and the patient develops a recurrence. It is always much difficult to fix that than a post SB situation. So therefore, in that sense, a scleral buckling is more forgiving. And of course, the bottom line is, let us all accept it. The scleral buckle definitely is the cheapest surgery you can do for a retinal detachment. So having said all this, when would I do a scleral buckle? A phakicardy of the peripheral atrophic breaks, no PVD, usually young myopes. These are best suited for a buckle, and young age myopic eyes, phakicardy due to dialysis. Remember, in a dialysis, the vitreous is attached to the edge of the dialysis. Very difficult to go and remove all the vitreous attachment, especially in a young phakic eye. You might end up touching the lens. This is best is to do a buckle in this situation. In patients who have iris claw lens or an AC IOL, where you're worried about the gas displacing the IOL, if you can buckle the eye, nothing like that. These are two diagrams. One is both are phakicardies. One has atrophic breaks in several quadrants. I would still prefer to do a buckle in this situation. Here, there are two large horseshoe tears. In this situation, I would rather do a vitrectomy because I am sure of relieving all the traction permanently. So in conclusion, scleral buckle has fallen from its premier position as the first choice. Kumar, I'm sorry. However passionate you are, as far as buckle is concerned, you're not going to win over people. You're not going to convert many people to turn to, scleral bucklers. So multiple factors are responsible. We have gone through all that. More importantly, as the number of buckles we do becomes less and less, how can we train the fellows? See, I did 70 buckles or 80 buckles in 2008, and now I'm doing only 30 buckles. So obviously, the fellows are exposed to less and less of buckles. So that's the fact we have to accept. And maybe the newer, trends like chandelier-assisted buckle may change, may revive this dying art. If that doesn't happen, scleral buckling may disappear from textbooks like what intracapsular lens extraction did. Thank you.